Yeah, my name is Bill Stoops. I am talking to you today as the interim director of the CRSO. So how many of you had heard of the CRSO before you saw the announcements about this talk? Oh, good. Okay, all right, because we've been to some departments and they're like, what? Who are you? So that's good. I'm glad that we've got an audience at least somewhat familiar with where we're with what we're doing. So we've divided the presentation into 3 parts. I'm going to give a background and an overview. Anna is going to talk about implementing the clinical trial management software, or the CTMS. We also call that OnCore. That's the actual software's name. And then Marietta is going to talk about where we are with the progress in building and implementing the CRSO. So the CRSO comes out of the UK TRACS initiative. And we love our acronyms here in the College of Medicine at the University of Kentucky. So TRACS stands for Transforming Clinical Research Administration, Culture, Technology, and Service. So TRACS. And our goals in the TRACS initiative were to reduce burden on study teams, to make it more efficient and easier to do clinical trial research. We wanted to provide sort of enterprise-wide, university-wide way of tracking clinical trials, because believe it or not, we have no way of telling you how many clinical trials we have at UK or how many clinical trial accruals we have at UK. And I know that this is being recorded, so sorry, that's not allowed to be said. But we need those metrics. We actually need this information for the CCTS grant. We're going to have this information going forward. We, of course, want to make sure that our regulatory and financial management is more efficient, and we also want to keep people from going to jail. So this helps us bill more effectively and efficiently, track subjects in research, determine what is billable to Medicaid or Medicare, what is not, and make sure that we are acting appropriately. So just to give you an overall implementation timeline, this work started over a year ago. I mean, but here we've got June 2018 sort of as a formal starting date when we began to sort of build the base of the CRSO and start planning. Forte is the company who makes OnCore, who makes the clinical trial management software. When we started engaging with them to implement OnCore more broadly, we sought input from working groups. I was on a working group. I didn't know I was going to get this job until about November. So I was on a working group first. And then have since been appointed as the interim director. We've developed some draft SOPs, and now we have officially transitioned to implementation, starting with Markey. Anne's going to talk a little bit more about that in a second, and continue implementation activities on into the future. And Anne will give some more details about how we are implementing and who we are implementing with right now. So something that was really important to us was that this be a collaborative process with input from stakeholders. So as a faculty member in a basic science department, I experienced the creation of the IBUs. And that was really tough for a lot of us. And we wanted to be sure that this was a little bit more collaborative, sought input from stakeholders in a way that we were making sure we were trying to do things in the best way as recommended by the most people possible. So we had different working groups: protocol, calendar, setup, build, budget and pre-award, participant tracking, post-award, regulatory. I was on regulatory. And we had a bunch of different workflow processes that we knew we needed to create for the CRSO and in the clinical trial management software, and completed all of this stuff as scheduled with the help of Huron, our consulting company, and had great input. And a lot of you are in this room, so thank you if you're on a working group or multiple working groups. And what basically happened was that those recommended workflows were brought to the CRSO steering committee, who blessed them or made changes as needed going forward. So we sort of had a working set of guidelines that we wanted the CRSO to be as we were implementing it. So something that I think is important, because a lot of people are asking, how does this affect me? How does this apply to me? We want the CRSO to help folks do clinical research, but we're specifically interested in studies that meet the NIH definition of a clinical trial. They do not have to be NIH funded. They can be industry funded, they can be foundation funded, but they meet the NIH definition of a clinical trial. We want to capture those in our clinical trial management software. But we're going to capture different types of information in the software. So anything that is industry sponsored will have the protocol built into it. you'll actually be able to track subject visits over time. So the coordinator can go in and check that the visit happened. And that sort of fills to a calendar and allows financial pieces like budgeting and billing and invoicing to happen, so that we are invoicing sponsors and segregating out charges that would go to a participant's insurance or Medicare, Medicaid appropriately. Anything that is non-industry sponsored but also has billable services, we're going to do a similar level of build into the clinical trial management software. If it's non-industry sponsored, cancer related, without billable services, we just need basic information about the protocol. That's that's things like the PI, does it have a clinicaltrials.gov number, some real basic information, and summary accrual. We're asking for quarterly accrual put in, so we can know how many people are accruing to clinical trials, because again, we have to have that for our CCTS grant. And actually, all of my work pretty much falls in here. So it's NIH definition of clinical trial, non-industry sponsored, non-cancer related, and no billable services. Everything I do is research. So what and my protocols are getting built in too. So and it's really not painful at all. The protocol gets built in and summary accrual. I'm actually going to do a little. You can do a little bit more granularity, and you can take that summary accrual information. So I'm going to put some more demographics in about the participants I accrue, because then I can pull that straight out, turn it into the IRB continuation review time, turn it into NIH when it's progress report time. So it's just a little bit of extra work quarterly. I'm going to be able to have some efficiency there. And let me tell you also, it's important to know that our CRSO team is going to be the groups who are building this information in. For anything that's existing, and we'll talk about this in a little bit, we're going to ask you for some help with that in terms of information we need from you, but we're going to do this work. We're not asking the investigators to do this. We'll ask you to check it to be sure we've done it right, but we're going to do this. So now Anna's going to talk about implementing into the clinical trial management software.
Okay, so the clinical trial management system, or OnCore, is a tool for us to be able to effectively manage our trials. There are a lot of workflows and processes that are outside of this tool, but it is a tool, it's a software. So again, to a little bit more detail into where we are with our timeline. Markey has been using OnCore since about 2006. So for all the cancer studies, they've already been in there in some capacity. We recognize, though, that they weren't fully utilizing the capabilities of that tool. So we have taken Markey's application of this system and have transitioned it from Markey servers to what we call FMI, or Forte Managed Infrastructure, so that Forte is supporting this on their servers now. So we've transitioned to what we could call a cloud-based service, if you will. We are expanding Markey's use of this tool. So they are using the financial capabilities of this system more robustly now, and that's what we are literally working with them right now to build out. Literally right now, they're upstairs, downstairs, wherever we are, building out the financial components of these protocols. And so in doing that, we've had a lot of sessions that surround the financial processes and capabilities of the CTMS to enable that. We are interfacing with two systems. So OnCore will be interfacing with demographic information out of HQPM. We're going to be pulling down the data from HQPM, certain data points. This will help a lot with mechanizing reporting, making sure that we are using HQPM as a source of truth. And again, literally right now we're having conversations about making sure that we understand how to make corrections to HQPM when we see errors. But that's a feed that we are working in the background to set up, and we have an amazing array of support from IT teams helping us build that out. The second interface that we're working with is an accounting interface with SAP. So we are going to push information to SAP about our accounts receivables, and we will be pulling in payment information as well. This is a great turn of events, I think, too, because clinical trials usually run on a cash basis. What did we receive? This way, we're going to align the information we have about our clinical trials with the accounting practices of the institution to be accounts receivable based, and they will be able to report on that. We, as of Friday, have made that determination that July 1, at the start of the fiscal year, will be our goal for activating that interface and making sure that our live feed is supported going forward with accounts receivable starting in the fiscal year. Markey will be probably the only group that's utilizing that interface to start. We might have a couple of others in there at that point. But, and of course, we started with shifting over. How many of you have heard about our coverage analysis process? Wow. So, okay, good. So as of March 1st of this year, we've transitioned the coverage analysis process from what was formerly known, well, probably known as many things, but more recently known as the insurance coverage analysis, or ICA process, that UK Healthcare Compliance was doing. The CRSO is now responsible for performing the coverage analysis for the clinical trials. So if you haven't heard about that and you have a study, please get in touch with us, because that entire process is a little bit different. It's shifted in the timeline of when we want the information and the type of feedback that we're providing to you. So that's something that we're actually live with. It's living sort of both outside of the CTMS right now and is starting to integrate into the CTMS as a tool as well. There's a lot on this slide. A lot of important things. Right now, though, we are, again, like I said, we're starting with Markey, as we've mentioned. So we're working on every one of their protocols that need to be adjusted in the CTMS. We're meeting with them regularly, and we've started our engagement with Sprint 1B folks, and so that's where you see that we are here. We will then, we've split this as a rolling transition, not a big bang go live for 100% of our units and departments. That's a little bit too much to take on at once. So that's why we're doing, throughout this calendar year, a lot of interactions and collaborations with departments and units to get their studies in the system and to teach and train and make sure that we have the information we need in there. And so this is where you see that fall out. We've got internal medicine, cardiology, pediatrics, orthopedic surgery, behavioral science, radiology. We've been meeting with them initially, and what we're doing is targeting the prioritization of what studies should go into the system. And so again, that's a very collaborative process. We need to learn from your teams what is best to go in the system and how do we best support that build. We will need documentation, obviously protocol, scheduled events, consent forms, IRB approval information. We will collect all of those documents based on how we prioritize the studies and work with everyone to get the education that they need about how they will use the system. If not in Sprint 1B, then basically it falls to Sprint 2. And our goals for going live are essentially targeting somewhere in the vicinity of these months that we have listed here. We need that to be flexible. So based on the volume of the studies that each team has, and based on the particular needs of getting those builds created for you. Right now, we're still targeting the very last day of May for Markey Go Live. They may have to push out a little bit. We've had some reconfiguration of the calendars and things. But again, we're trying to be very flexible and collaborative with how we're putting information in to benefit you. So same thing with the September. We think that we will have a couple of teams based on volume, probably ready and live in the system well before September. maybe in line with the beginning of the fiscal year. And we'll keep working through that with you all individually and others. Oh, this has motion.
Yes.
And I don't know the motion, so we're going to learn together. So OnCore CTMS is a system that is set up to obviously manage your protocols, have your study calendars, apply a billing grid on top of those calendars so that you have insight into designations from your coverage analysis. Should this be billable to the patient and their insurance, or is this a research element, or is it time and effort really associated where I still need to seek some compensation from my sponsor? Somebody owes us money for this work. So that will be applied on the calendar. The budget is applied as well, so it's a great tool for financial folks to utilize and keep up with what am I getting paid, where are we falling short, what do I need to invoice, what's coming automatically from CRF completion, all of that. Subject management, of course, we could not be in our supportive roles without the amazingly hard work of clinical research coordinators and clinical research nurses. Can't speak today, excuse me. The subject management piece really is supportive of those individuals and investigators. You're patient facing, and we need to know, in order to be able to support what you're doing, the important scientific work that you're doing with patients, we need to be able to know a little bit about what's happening with those participants in order to make sure that we have the correct invoices going out, that we understand changes to billing designations based upon patient-specific information and patient-centric issues that have arisen during your study. And so coordinators are going to be utilizing the CTMS tool and provided training, ongoing training, as to how to best utilize the system, which is inclusive of visit tracking. And there's a lot of great communication pieces back and forth so that we know what happened on the visits, and invoicing, and of course reconciliation. Demographics, invoices and payments. So all of these things that we've been touching on. This is our supportive tool to make sure that we are able to track and report based on these things. Okay, I didn't know if it had any more. Okay. Training and roles. Okay, so we touched on the fact that this is things that the CRSO is doing and the requirements of getting clinical trial information into a system. It's a huge undertaking, especially at an institution this size. You're not going to be just thrown to the wolves. You're not in it for yourself and by yourself. We have teams in place, hopefully ever-growing teams in place as well, to keep you apprised of what you need to do, how to access things, and the ongoing support to be able to use it. And so we have, obviously not, when you get access to a system like this, your access should be based on the roles and the business need that you have to use the system. So not everyone has just carte blanche access to this tool. There are obviously high-level reporting needs, administrative level access, but really it needs to be focused on the protocols that you're responsible for and the role that you play in carrying out the elements of that protocol. So we will be speaking with each team as we're talking through legacy build, as we're talking through what needs to be in the system, what roles need to be created for your teams to be successful, and then we'll be designing the training focused on those roles and responsibilities. And I think I've touched on some of this, most of it really. But basically we started trying to, as Bill mentioned, as you all are very well aware, there's not a single place right now until we get this up and running where we can locate all information that we need about our clinical trials. So we've got a bucket of information coming from the IRB and a hodgepodge of information coming from a spreadsheet and a sticky note in different places, but no one repository. So we started manually compiling, many of you out here helped us with this effort. We started manually combining last fall an approximate volume picture of what we have here at UK. We have, as you are also well aware, that can change moment to moment. What studies are active, what studies are open to accrual, what's closing tomorrow, those things are very fluid. So we recognize that our inventory that we performed was just a baseline, and that's what we're working through with you all now as we talk through what has to go in the system. How do we revise that, and what needs to be built in the system based on our minimum footprint criteria. But that's a minimum. So there are some departments, when we met with pediatrics, they were excited about the utility of this tool. How can we put some more studies in there? How do I get my registries in there? What can I use the system for so that I can make it work for me as a manager or as an administrator of our department? How do I work with you all to get key information into the system? So we will continue to work with you all individually on how that functions. And the documents piece, of course. And that's where that partnership comes in handy. We will need the time and effort that it takes to get some of those documents to us as we build it out. And that's an ask of us, and we know that that is a resource that you're short on time. Everybody's working hard. But in order for us to make this really work for you, we really need that support from you as well. And this is a very simple chart of some of the thought that we put into how to prioritize, what to build. Obviously, basically, a simple way to look at this point is if there's going to be activity on this study after this calendar year, then we probably need to go ahead and put it in the system so that you can be working on tracking that activity. But that's about the most simple version. If you're just starting up the study, we want it in there. If it's open to accrual, we're going to put it in there. Really, where it gets more tricky is sort of hedging. How much information do you really need about a study that's recently closed, where you're not really going to be engaging financially with that very much longer? We can make some determinations about that, again, at that local level with your team to determine the amount of work that needs to go into building that versus the utility of reporting that you might need off of it as well. So I think I'm moving to Marietta.
Good afternoon. It's been a little while since I've actually got to stand over here and talk with you all, so I'm back on my game here. I'm going to talk a little bit about the CRSO progress up to this point. For a long time, Ann and I served as a team of 2 for the CRSO, so we're happy to report now that we actually have a full CRSO team in place. We have our CTMS administrative group, which is actually led by Jen Simpson, with our CTMS specialists who are doing the calendar builds into the OnCore system, as well as an OnCore trainer that's in place. We do still have one position in that unit that we're going to hire for a report writer to help us be able to pull the information that everyone is putting into the system out a little bit easier. Our research billing integrity manager, Adriana Jenkins, is leading that team. We have actually 2 research coverage analysts functioning in that, and we do have one position left to hire into that unit within the CRSO. Our clinical trial financial team is led by Jessica Heskell. She has 2 research budget analysts, and we are still have one position for the invoicing specialist for that team. And then the regulatory program group, which I lead, was actually already established within the CCTS, and that team has actually remained intact with Laura leading that group. So in the research billing compliance program, as Ann mentioned, effective March the 1st, the CRSO team took over the coverage analysis portion from the UK Healthcare Compliance Group. We've concentrated on introducing the new process and educational efforts into how that is going to work. We are aligning the appropriate order of events, so the new coverage analysis process will actually help inform budget development rather than being done on the back end after the budget has already been completed. And it also can be done prior to IRB approval now, where before you had to have IRB approval in order to be able to get your coverage analysis done. Just a quick reminder for those of you that have already worked through the process and those of you that may not have done that yet, for studies that have already completed budget or coverage analysis prior to March the 1st, we are not going to redo those coverage analysis. But if you do have amendments on those studies, we do actually want to see those amendments. And then it's very nice now, the new Excel spreadsheet that you get after your coverage analysis is completed that will show you exactly what is going to be approved and billable under the coverage analysis. It's a very nice spreadsheet that you get now in response to that. So in the future state, we are going to continue retraining to coincide with our OnCore rollout as we get ready to build the coverage analysis component into OnCore. We are creating a new formal intake process, so we'll be meeting with study teams up front to start working through all of the startup activities that need to happen, as well as working through the coverage analysis process. Then we've got some Excel grids that are converted to OnCore as part of the legacy build, so we'll be able to provide those coming up. And then the new workflows for the coverage analysis will actually be put into the OnCore system as we begin to get the studies up and running and rolled out into OnCore. So the coverage analysis volume, I'll thank Darren for actually pointing out that we have a couple of errors and some addition here, but we knew going into this, as we started to roll out in March, that we were going to have a fairly large volume of studies coming in the first month. So in the month of March, we actually got 34 requests in. We have started to see a decline in that in April, and we suspect that that will actually even out over the next few months. The other thing is that we anticipated early on with that large volume that we were going to need some additional help. So we contracted with the Huron team to assist us in getting the coverage analysis completed. And then we actually started getting all of our folks trained and up and running and so that they would be able to perform the coverage analysis here on site at UK. So we're rolling out into that process. And so as we're moving toward doing more here in-house, we're actually seeing a reduction in the amount of time that it's taken us to get the coverage analysis done. So I won't go through every number that's on this chart, but I think it's worth taking a look at kind of what the volume is that's actually going on here at the institution. So for amendments, we just started looking at amendments starting in March. We only saw a few amendments come in March, but as more and more folks are getting aware of the new process, we're starting to see an increased number of amendments. And it's important to note that amendments that are administrative may not actually require a coverage analysis, but for right now, we want to take a look at all amendments that are coming through just to make sure that we're catching everything that we need to review in that regard. So a lot of people have asked about the CRSO website, just a few quick updates. In that regard, we actually have a CRSO website draft. Now we have most of the components that we wanted to include. We've got a meet our staff page so that everybody can actually meet all of our new staff members and our CRSO team. A list of our services that we're going to provide. the information about OnCore and the CTMS. We've also incorporated a service request form link on there so that it'll be easy for you to request CRSO services. And we're hopeful that here in the next month or so that we'll be able to actually roll out our first CRSO website. So we are moving forward with that, and hopefully we'll get that up and running quickly. So what are our next steps? We're going to continue working on hiring out the rest of the CRSO team. And we're going to continue to finalize our policies and our procedures with input from you all and our CRSO staff on how the best way is going to be most efficient to implement all of our processes that we're going to have to do to make our office run. We're going to continue working through the intake process. We are doing that in partnership with the CCTS, and we want to make sure that that runs smoothly for the investigators and that they actually have one point of contact. We're going to continue to collaborate with RFS. This will be the first time that we've actually done that. And so we want to make sure that that's working well for you all and for our industry sponsors and for our study groups, and make sure that the CRSO team is monitoring that, and that we stay on top of any questions or concerns that arise as we start to implement the new RFS process. Jessica's actually been working really hard with the RFS team to make sure that that goes smoothly. So we're anxious to actually do that for the first time and see how that's going to go. And then again, we're hopeful that we're going to be able to get the website up and running soon. So now if anyone has any questions, for any of the three of us, we'll be more than happy to address those.